afternoon, everybody. My talk today includes the radiotherapy options for basal cell carcinoma, which we have studied in University Hospital of North Midlands in UK. We will go through it. This is the commonest malignancy. If you put all cancers together, still the number of patients with basal cell carcinoma is higher than that. It has not only have healthcare implications, but also has a burden on the society. So we will discuss it today. So what we have to discuss today is an overview of basal cell carcinomas and also the outcome of radiotherapy treatment for basal cell carcinomas in an elderly population group in our hospital. We will assess the cure rates, complications, and the regimens used. Let's talk about back to the basics, the background and epidemiology. As you know, basal carcinoma is the most common cancer in humans, with increasing incidence worldwide. Men are generally more involved, but women are also having it. Basal cell carcinoma is more frequent in a geographical location which is more exposed to ultraviolet radiations, but it is actually prevalent everywhere. Generally, our population is increasing. Hence, the incidence of basal cell carcinoma is also rising, and it will continue to do so in future. Many studies have shown the incidence varies from different areas from 88 to 245 per 100,000 persons per year. Although mortality is very low, but it can cause local tissue damage and sometimes it is a nuisance and it hardly metastasizes. The incidence of metastasis is from 0.0028 to 0.055%. And usually it, metastatic form is found in the lymph nodes in the region, and sometimes it is found in the lungs and bones and the skin. But 80% time it goes to the regional lymph nodes. But it's very rare. It only happens when someone is immune compromised, especially with HIV patients or patients on immunosuppressants. Now, the etiology and pathophysiology is wide ranging. Mainly, it is the cumulative exposure to ultraviolet radiations. And usually it is ultraviolet B wavelength, which actually damages the DNA directly. It causes erythema, but UVA can also cause damage to the DNA indirectly by going deeper and also releasing the radicals there. The skin type is also very important. The fair skin Caucasians are more involved, and Fitzpatrick skin classification has shown that Fitzpatrick skin type 1 and 2, when the melanin is very low in this skin, they are they are actually more prone to get. So this is a risk factor for them. As person ages, the risk of basal cell carcinoma increases, and it is more prevalent in immune compromised patients, especially HIV patients, and also patients on immunosuppressants like rheumatoid arthritis or ulcerative colitis patients. And there is also a risk involved with the arsenic exposure. Arsenic is normally is present in certain geographical areas, and also it is man-made pollution. So sometimes it can actually affect the skin and can lead to skin cancer. Apart from the environmental factors, there are other factors as well, like genetic factors. The most commonly is the pathway which is called patched 1 mutation, which can lead to Gorlin syndrome, which is a nevus basal cell carcinoma, and it has led us to understand the pathophysiology of this cancer. Especially, it can affect sporadic cases as well. There are several other genetic mutations are found. In 20% of patients, smoothened gene defect is found, and in 80% of cases, patched one mutation is found. But there are other genes as well, like glioma-associated oncogenes. So genetic mutation in several tumor suppressor genes and proto-oncogenes has implicated development of basal cell carcinoma. Now, orig- the the first time when it happens, the patient goes to the primary carer with a simple papule somewhere in the face or other areas of the body. In UK, it is not on two-way referral system as other skin cancers like squamous cell carcinoma or melanoma. If it is not diagnosed properly, then it can cause local nuisance and can cause tissue necrosis, especially if it is near the eyes. It can affect the vision and it can sometimes damage the nose or ear. Now, how to evaluate a basal cell carcinoma? So best is actually to take a proper history, a history of more than 2 years, any lesions there slowly growing has to be investigated. It can have crusting, bleeding, non-healing ulcers. There might be past medical history of sun exposure, and some patients are actually visiting to those geographical areas where UV ultraviolet radiations are higher, and the previous history of radiotherapy, Corlin syndrome, immunocompromised patients, or patients on immunosuppressants. Examination is done holistically, and usually it's a raised or purely white margins, telangiectasia, arborizing arteries, and sometimes it is good idea to examine dermoscopically. And on dermoscope, it's quite clearly seen arborizing arteries and bluish pale nest-like structures, and sometimes we can actually see the leaf-like bluish structures surrounding these blood vessels of telangiectasias. This is a typical patient of basal cell carcinoma. If you can see here is a purely white, purely color and also surrounding edges with a central depression. So this is very near to the eye of the patient. If it is not treated in time, it can lead to damage to the lower eyelid. Usually it is picked up very quickly and referred to the hospital. Now coming to the evaluation is, as I said, is very important. So clinical examination, holistic clinical examination of all skin is very important. And usually a fleshy colored nodule is seen on the surface with telangiectasia on the surrounding margins. Most commonly, it occurs on the face, and usually the facial areas is nasolabial folds, nose, ears, and on the forehead. So these are the areas where basal cell carcinoma occurs, and this is the area where most of the ultraviolet, cumulative ultraviolet radiations are exposed to. Although the skin examination, additional cancerous and precancer lesion is very important as well. Coming to the histopathology, it is a epithelial tumor. So the epithelium has four layers. On the top is the stratum corneum, and on the bottom is the stratum basal. This is the stratum basal here on the lower part. The stratum basal has now these lesions which can be seen very easily here. And this one is basiloid cell with scant cytoplasm, elongated hyperchromatic nuclei, and peripheral palisading is also seen here, and peripheral clefting is also seen with mucinous alteration of surrounding stroma. Now, There are around 26 different types of basal cell carcinoma described in the literature. Mostly it is classified depending on the clinical features, and sometimes it is classified depending on the histological features. Nodular is the commonest type. It is 60%. Rest of it is uncommon, like cystic, ulcerated, superficial, morphic. Morphic is slightly more aggressive nature of basal cell carcinoma. There is also another uh, kind of basal cell carcinoma where there is a pigment. The pigmented basal cell carcinoma is normally 10 to 20%, but sometimes they are more aggressive, like infiltrative and basosquamous. In basosquamous, the features of basal cell carcinoma and and squamous cell carcinoma and basal cell carcinoma both are present. Now, coming to the management, management should be done with multidisciplinary approach, and usually it has to be assessed the site of the lesion and whether the patient is having a lesion which is locally destructive or non-destructive, and we have to assess whether he is fit for surgery. We have to assess non-operative areas, for example, near the eyelids and ears, and also near the nasolabial fold and nose. These are the areas where we have to think about non-operative approach, and also there are other features. For example, patients is having concomitant medications. He is very elderly. He's not fit for surgery. So many factors are there to actually assess whether he goes for surgery or whether he goes for non-surgical treatment. Radiotherapy is one of the options actually which can be employed either on its own in certain sectors of the population who are elderly and where the surgery is not possible or contraindicated. This can be given with electrons, beams, or with superficial external beam, but other uh, non-operative management is also available for BCC. These non-operative measures are conservative. Sometimes patients having some 5-FU creams or Aldara creams, immunomod, or photodynamic therapy, cauterization, cryotherapy, where the liquid nitrogen is given to the lesion to lower the temperature to -60 to actually kill all the basal cancer cells. The lasers are also sometimes employed. The pulse lasers are given, but the efficacy is not that great. Radiotherapy, we will discuss it detail in the later slides. Sometime we encounter there's no histology and patient has not had a biopsy, and it's sometimes not possible to take a biopsy. For example, very near to the eyelids or on the eyelids, where the biopsy is sometime not done or not possible because it can damage the eyelid. And sometime we have to see whether certain areas we can actually use with Aldara cream or Emmercord with with a clearance rates of 82 and 94%. So careful selection of patients is very important. So that's why it's important that multidisciplinary approach is actually adopted. Now, in the surgical treatment is the gold standard treatment. This can be standard surgery or Mohs micrographic surgery. And coming to the primary management of basal cell carcinoma, which is historically done with the surgery, and which is very good and excellent prognosis with the Mohs micrographic surgery, the recurrence rate is 1%. With standard surgery, The recurrence rate, depending on different sites, is around 10%. With radiotherapy as a primary modality, the recurrence rate is around 10%, again, 8 to 10%. But some studies are showing superiority over radiotherapy, the surgical procedures. But patients sometimes cannot undergo surgery. But Mohs micrographic surgery remains the gold standard for clear margins. For standard radiotherapy, 4 millimeter margins are uh, are enough. And sometimes the standard say after standard radiotherapy, margins are not clear, and on that case, patient would require a further excision or radiotherapy. This is an example of how big a surgery can be. For example, this is a nasolabial fold of to treat a small basal cell carcinoma on the ala nosi. The size of the tumor is 1.5 centimeter, but the operation of nasolabial flap fold is quite big actually, and surgery involves is quite extensive. And this patient has got anesthesia, and it has got all those surgical complication which is possible in this situation. Sometimes we need to have a full thickness skin graft, and if patient is on anticoagulation, it is very difficult, and it can lead to bleeding for some patients. And this is the split thickness skin graft, and this is taken from the thigh of the patient, and this is the result, and the result sometime is cosmesis. This is on the scalp. It is covered with this one, and the skin graft is done on the scalp, but the cosmesis is a problem here. Now, sometimes we end up having complications with uh, split skin grafting or nasolabial folds with necrosis or graft rejection. Sometimes it is catastrophic in nature. So NCCN guidelines have been issued this year in 2020. They say that curettage, when there is a low risk basal cell carcinoma, all basal cell carcinoma, all these options are possible. It can be curettaged with electrodesiccation, or it can be treated with standard excision, or sometime it can be treated with Mohs micrographic surgery. If margins are positive, then it can be re-excised or sent for further radiotherapy. But radiation therapy is considered for non-surgical candidates or those patients who are not fit for surgery. Similarly, ASTRO has issued the guidelines for definitive and post-operative radiation therapy for basal and squamous cell carcinomas of the skin last year. These guidelines provide recommendations on the use of radiation therapy to treat patients diagnosed with most commonly occurring non-melanoma skin cancers, and they suggest the dosing and fractionation also, and they suggest that if patient is not fit for surgery, they should be offered radiotherapy. They also discuss other options like chemotherapy and biologic and immunotherapeutic agents in detail. Now, management with the radiotherapy is important. Sometimes radiotherapy is chosen for elderly patients on its own, and we chose those patients depending on their comorbidities, and if they are having patients who are not able to undergo surgery, and those patients who are on anticoagulations, and also for those patients who have concerns with the cosmesis and certain areas where the surgery is not very favorable. For example, on the nose, around the eyes and nasolabial areas, and also on the ears. And there was a presentation from Tirmizi et al. At National Cancer Research Institute conference in 2014, where they presented hypofractionated versus standard fractionated radiotherapy for non-melanoma skin cancer with quite good results with very low recurrence rate over 5 years for elderly populations. Now, fractionation and dose of radiotherapy use depends on the tumor and the patient characteristics. So the anatomical area is also very important. Sometimes we have to assess the fat content of the area, and also we have to assess whether the radiotherapy is being given in the extremities or on the face. As you know, basal cell carcinoma is most commonly occurring in the face. So we have to see whether this radiotherapy is more beneficial on these areas. And also the size of the tumor is also very important, like diameter and the depth of the tumor. And the dose also increases with the depth of the tumor. And also the patient's ability to come and attend the hospital clinic appointments and the visits of the hospital for multiple fractionations. So some patients are very elderly and they're not able to come to hospital on repeated calls. At present, there is no consensus on radiotherapy dosage or fractionation to treat basal cell carcinomas. Most papers and guidelines suggest minimum of at least 5 fractions of radiotherapy, while others have shown success with single fraction. There was a presentation by Tirmizi et al. At UCRO conference in 2013, where hypofractionated radical therapy was presented for non-melanoma skin cancer in elderly population with very good results. Now, the Royal College of Radiologists recommends following regimens. So if tumor size is less than 3 centimeter, then a single fraction from 18 to 30 grays are usually sufficient for elderly population. But if tumor size is 4 centimeter or less, then 5 fractions of 32.5 to 35 grays should be employed over 1 week or 5 days. Any tumor more than 4 centimeter, depending on the size and the depth, it these following dosage are considered. One is 45 grays in 10 fractions over 2 to 3 weeks, or 50 grays in 15 to 20 fractions over 3 to 4 weeks. And the last one is 55 grays over 20 fractions in 4 weeks. And in different parts of the world, different people are actually using different regimens to treat basal cell carcinoma as a primary treatment. Aim of our study is actually to review outcomes of patients with primary basal cell carcinoma treated with radiotherapy at University Hospital of North Midlands. Now we have actually selected patients which reading their records from the hospital record systems electronically. Patients' demographic was studied, and we have actually studied the tumor characteristics. We also studied the radiotherapy regimens, and also we have studied recurrence rate and the survival outcome of these patients. So a retrospective review of medical records was performed for patients who underwent primary radiotherapy between January 2014 to December 2015. And this is the inclusion criteria. And we actually followed these patients for 3 years, and patients were undergoing radiotherapy as a primary treatment modality for basal cell carcinoma during that time, and our primary endpoint being recurrence-free survival. So the results of this study was the total of 166 patients were identified with 186 individual tumor sites treated. Males were slightly higher than the females. The median age of patients were 87 because it was an elderly population. The median time from biopsy to first radiotherapy session was 3 months. The majority of the tumors were from head and neck region, with the nose being the most common site. And histology has shown different commonness was 42% of the lesions. So these are the results of tumor characteristics. If you see, most commonly it is on the face. 86% is on the face, 8% were from the scalp, 2% were from the torso, and 4% were from the limb. And if we subdivide the facial lesions, we come up with the nasal was the most common, 32%. Temple was after that 22%. Forehead was 14%. Ear was 8%. Eye was 7%. Neck was 7%. Mouth was 6%. And cheek was 6%. Now, the results of tumor characteristics histology. If we go on to the histology, the 42% were nodular and 23% were infiltrative, and 9% was morphic, and 7% were micronodular, and 18% were others, which were like a mixed kind. Now, we have used the following regimens in our center. In the most cases, superficial orthovoltage external beam radiation therapy was used with 100 kV X-rays. External electron beam radiation was used very rarely. Maybe it was only for 1 or 2 cases. Field size ranges from 2.6 centimeter to 6.8 centimeter. Medium size was 2.6 centimeter. So radiotherapy dosage and fractionation which we use was, first was which was quite common, 70% of cases we have used 20 grays of single fraction. Usually this was used for lesions less than 2 centimeter or less than 3 centimeter. And the second regimen was 30 grays, 3 fractions, which was almost 23% of times. And 35 grays, 5 fractions were 3%. 45 grays were rarely used also with 10 fractions in 4% of patients. So depending upon the size of the tumor, 70% of patients received single fraction of 20 grays and 24% received 3 fractions of 10 grays once weekly, total dose of 30 grays, and the remaining received 5 or 10 fractions daily, 35 grays or 45 grays respectively. Now, the radiotherapy field size plus regimen, we have already told that the main field size was 2.6 centimeter, and it ranges from 1.2 centimeter to 6.8 centimeter. The treatment response. Now, there were 4 recurrences over these 3 years period, which is 2.2% over the 3 years follow-up period of 169 patients with 97.8% recurrence-free survival. Of those with recurrence, 3 received a single fraction and other 10 fractions. 3 patients developed complications following radiotherapy treatment. It comes like 1.6% with radiodermatitis, in two patients and non-healing ulcer in other. But 28% patients were diseased at the end of the 3-year follow-up period. This is worth noting that no death were related to basal cell carcinoma because this was an elderly population. Now, with regards to this treatment which we have actually given and the outcome, the study identified that the hypofractionated radiotherapy regimen used at our institution offers good 3 years recurrence-free survival with minimal complications. The frail and elderly extent of the population is shown by the mortality rate over a quarter of 3 years unrelated to BCC or to the radiotherapy. Although the surgery is often used as a primary modality for curative treatment of basal cell carcinoma, radiotherapy is equivalent in many clinical scenarios and also has a role in the adjuvant setting. There is no consensus on the radiotherapy role with treatment of basal cell carcinoma due to the lack of high quality evidence. The radiotherapy for basal cell carcinoma produces good outcome in terms of local control and toxicity. A single fraction of 20 grays applied to the surface was found to be a reasonable option for lesions less than 3 centimeter in those patients who have difficulty in attending hospital visits. We use this single fraction of regimen as definite treatment or for majority of patients. This is there is a lack of prospective randomized controlled trials in this setting. That's why ASTRO has suggested to include patients in randomized controlled trials when we treat basal cell carcinoma in the recent guidelines of 2020. Clinicians still differ in their selection of radiotherapy regimens in different parts of uh, the population and different parts of the world. The Royal College of Radiologists in the UK have said some examples of acceptable regimen like single fractions of 18 to 20 grays, usually in elderly population, and 22.5 to 35 grays in 5 fractions over 1 week with small lesions less than 4 centimeter, and 45 grays in 10 fractions over 2 to 3 weeks, and 50 grays in 15 to 20 fractions over 3 to 4 weeks, and 55 grays in 20 fractions over 4 weeks. The regimen that we have used requires fewer visits than the other multi-fraction schedules and is effective. It is also popular with the patients and their carers. Now, conclusion is that hypofractionated radiotherapy, single fractions of 20 grays or 3 fractions once weekly with total dose of 30 grays offer good cure rates for basal cell carcinoma with minimal complications. It's a good treatment option for the majority of patients who are elderly or are frail, who are able to reduce their hospital visit by this regimen. But there is some limitation for our study. The follow-up period is 3 years. We will also tell that incomplete clinic follow-up of data for patients were there, and this incomplete data was due to the diseased patient who had died before their assessment, but their death was not related to basal cell carcinoma. Therefore, patients who died not represent in a 3 years period to secondary care were assumed as cured. Thank you very much for your time today.